Hello and welcome to another episode of the Health Notebook. Today we're discussing epilepsy and we have Dr. Motala in the studio. It's good to have you in the studio, Dr. Motala, and welcome.
Thank you.
Dr. Motala, can you just tell us a little bit about yourself?
Okay. I'm a neurologist. I did my undergrad in medicine at the University of Natal in Durban. I then studied for 4 years. I did my postgrad at the Inkosi Alba Lutuli Hospital, also in Durban.
Okay.
And I then, after I finished my postgrad, I worked for 2 years at the Gray's Hospital in Pietermaritzburg before I relocated to Cape Town.
Okay. So you studied at least 10 years in total to become a neurologist. Is that correct?
Yes.
Okay.
6 years undergraduate and then 4 years specialization.
And how are you finding Cape Town?
Well, I'm here 8 years now, so.
And you enjoy practicing in Cape Town. Okay. Today's topic is epilepsy. Can you tell us what is epilepsy?
Okay. Epilepsy is a neurological disorder that's characterized with the presentation of seizures. So a single seizure in a person's life does not mean that they have epilepsy. You usually have epilepsy if you've had more than two or more unprovoked seizures.
Okay. When we're speaking about seizures, in simple terms, can you tell the viewers what does it mean? What is a seizure? Is it that jerking movement, or what does it consist of?
Okay. A seizure occurs because of an intense burst of electrical activity in the brain cells, which is not normal. It basically, there's imbalance between the excitation and the inhibition of the brain cells causing excessive excitation. And it depends on a certain part of the brain that's been activated. So it can be locally in a local area of the brain, or it can be generalized involving the entire brain. And as a result of where exactly this abnormality is occurring, it presents as seizures, which is clinically different. So if it's localized in one area, the patient may have a seizure that's only localized to one area of the body.
And when you mean seizure, it means that there is a misfiring within the neurons of the brain. And how would the person actually present? So he would jerk, or?
So clinically, it depends on the site of where this abnormal excitation is.
Okay, so we've got different areas of the brain that is responsible for the way that we will react.
If it's a single localized region, example the motor region of the brain, so the patient may present with jerking or abnormal motor movement of one side of the body.
So when you mean motor movement, you mean that the arm
or the leg.
Okay.
You may have a repetitive jerking or of that specific limb, suggesting that it's in a localized area of the brain. However, there's generalized brain activation, then the patient can present with loss of consciousness or impairment in consciousness, and then they have generalized jerking involving the body.
Oh, okay. How common is this?
Seizures epilepsy is common. In South Africa, approximately 1 in 100 individuals suffer from epilepsy.
Okay, so you say 1 in 100. Can you just give us some of the risk factors or the causes of epilepsy per se?
Okay. There's lots of causes for epilepsy. It can be idiopathic.
Which means not known.
Idiopathic, where there's no specific cause found. However, there can be a genetic predisposition for patients with idiopathic epilepsy.
So when you mean genetic, you mean?
There can be certain genes that predispose you, a genetic abnormality within that individual that predisposes them to developing epilepsy, despite there being no overt brain abnormalities on an MRI scan.
Okay.
And so patients with a family history of epilepsy are more likely to develop epilepsy because of the positive family history, suggesting that there is an underlying familial predisposition. Then there are secondary causes. The secondary causes, there are numerous causes. Firstly, it can be developmental. The child could have been born with a developmental brain abnormality. Then there could be other secondary causes such as a brain tumor, infections that causes lesions, following head injury, following an accident or head trauma. Then even things like systemic blood abnormalities that can lead to seizures.
So you have your primary your primary epilepsy, and then you have your secondary causes, which can be as a result of existing diseases or injuries.
Yes.
Okay, so you mentioned earlier about the classification of epilepsy. So epilepsy is made up of seizures. So when would you define it to be epilepsy?
It has to be more than one seizure that's unprovoked. So basically, to be epileptic, you need to have recurrent unprovoked seizures. So a single seizure does not mean you have epilepsy. There is a 10% chance that anyone in the general population can have one seizure in their lifetime.
Okay.
And so they may never have a second seizure, which means they're not suffering from epilepsy. So if there is recurrence of the seizures and it's unprovoked, then that would help with with diagnosing epilepsy.
Okay. I go to the general practitioner. I give him the history of these particular jerky movements that I've had. What is the next step after taking the history to confirm epilepsy now?
Okay. Initially, as the patient gives the history, the patient doesn't usually give a full history. Most of the times, in the common forms of presentations of epilepsy, the patient generally has impairment of consciousness, of loss of consciousness. So they basically have a blackout and they have amnesia for the event. So that's where the family
Okay,
or
so when you
witnesses
mean
are very
amnesia,
important.
you mean loss of memory, or
They have no memory, they cannot recall the event.
okay, so no recollection of
Yes.
of that
So
particular
they might
incident.
remember everything up to the point of when they collapsed, but during the time of the collapse they have no recollection, and until they've recovered from the actual seizure, they may not remember that period of time as well.
Okay, so you've got your history, you've got some collateral history as well. Is there any specific test that you would do in order to confirm the diagnosis, or can you just elaborate on some tests or
Each patient will
investigations?
have to have a thorough physical examination. So we do a general examination, the general systemic examination, and the very important full neurological examination. This will identify if there is any abnormalities that would suggest a secondary cause. Usually in patients with idiopathic form of epilepsy, the examination will be completely normal. So the examination will give us clues as to whether we think it's a primary cause or whether a secondary cause. After the examination, we then proceed to do more ancillary tests. Some most patients we will do basic blood tests. Certain electrolyte abnormalities can predispose a patient to
So when you mean
seizures.
electrolyte abnormalities, in simple terms, what does that mean?
Example, the kidney function. There's various chemicals.
For example,
such
something
as
like sodium.
like a sodium or the potassium in your body.
Okay.
If there's irregularities, if it's low or high, those can also cause seizures.
Okay.
So there is a set number of blood tests which we do in order to exclude certain electrolyte abnormalities.
Okay. And how about a brain scan? How important
Once
is
we've
that?
done the blood test, we then do a scan of the brain to exclude a structural cause. So this would either be a CT scan or an MRI scan. There are two different scans depending on the specific hospital or the medical aid. The scan would be dependent on
Okay,
that.
so the scan it's done to identify if there's anything abnormal or any types of growths or anything within the brain that is actually leading to the seizures. Is that correct?
It would identify if there's any previous strokes, tumor, any developmental abnormalities that the patient may have been born with, or any other infective causes.
Okay, so now you've done the test, you've confirmed the epilepsy. What's the next step from there?
We can also do an EEG as well.
Okay.
The EEG is a test where we assess the brainwave activity. And in patients with epilepsy, 50% of the times the EEG can be normal, but we can also pick up abnormalities on the EEG. So that would be part of the test. Once we've confirmed the diagnosis of epilepsy, once we are aware that the patient has had recurrent seizures, at least if you've had 2 seizures, then we would commence the patient on treatment. There are various modalities available. It depends also on the type of seizure that the patient is having, the cost, depending on the cost of the medication, and depending on that we choose a specific type of treatment.
Okay, so when you say treatment, this is medical treatment.
Medication, yes.
Okay.
The medication is used to try and prevent the patient from having further seizures.
Okay. Does this mean that you prescribe the patient medication? Does he just use it for a week? Is it a lifetime medication, or how do you go about advising the patient on how to use the medication?
Okay. Regarding the medication, firstly, it depends on the cause.
Okay.
So the anti-epileptic medication is specifically for the prevention and treatment of the seizures. So if the patient has a specific cause, such as a stroke or a tumor, then obviously the modality of treatment will be different. You have to treat the primary. You have to treat the primary reason why they are having seizures, and then in addition to that, you treat them for the seizures.
Okay.
Right. So it also depends on the actual cause of the epilepsy. Once we've determined that there's idiopathic, or we know the cause and we've treated the primary cause, now we are treating the secondary cause, which is the secondary problem, which is the seizures. We choose ideally the treatment, and then we start the patient on it. We start on the lowest possible dose, because every medication has side effects.
Okay.
So you want to try the patient on the lowest dose that produces the minimal amount of side effects, and until we have optimal treatment, which is we monitor the patient regularly and assess the frequency of the seizures. Ideally, the patient should have no seizures on treatment.
Okay.
So if the patient is continuing to have seizures on that treatment, then it means we either have to increase the level of the drug, so the dosage will be optimized until the maximum amount that the patient can tolerate, and depending on that, we adjust medication.
Okay, so you either increase the dosage, you might decide to change the medication, is that correct? Or
Yes.
you might decide to add another medication?
Yes.
Okay, so now during this process, it also requires the patient to comply, meaning that he needs to come in, he needs to have his blood test done as well.
Yes. The patient has to be very compliant with medication. Missed doses, incorrect dosaging, taking the treatment at the wrong, incorrect time also can result in breakthrough seizures.
So when you mean incorrect time, it means if I was supposed to take it in the morning, I decide to take it late in the evening.
Yes. Each tablet has specific half-life. The half-life means that when I have a tablet, it gets metabolized in my body, and it remains in my bloodstream with a certain time frame.
Okay.
Example, 8 hours or 12 hours. So that determines whether you're taking a tablet as a once a day, twice a day, or 3 times a day dose.
Okay.
So if it is a twice a day dose, then you have to take it at a specific time in the morning, specific time in the evening, and you should be taking it at the same time in the morning and the same time in the evening every day.
Okay, okay. So we've spoken about the medication or the medical aspects. Can you maybe give the viewers some practical information? Okay, you've noticed a family member having a seizure. What should they do?
Okay, when a patient has a seizure, the most important thing is to prevent them from suffering any harm. The commonest things patients have when they have seizures is they develop injuries from the falls.
So they have a seizure and they fall to the ground.
They fall to the ground, and that's the commonest injuries that they suffer from is from the fall. So if you find a patient that's had a seizure lying on the floor, you should need to clear the area around it. So if there's any objects that the patient can harm themselves by hitting themselves on, we need to clear the area and to prevent them from injuring themselves. Then if they're wearing spectacles, spectacles can break and injure them, remove the spectacles. Preferably put a soft pillow or a cushion under their head to prevent their head from banging onto the floor and suffering from any injuries. If the patient is lying face down, you need to try and turn the patient to the sides to prevent them from, they may have difficulty with breathing if they're facing
down with the head
downwards.
down, okay.
Yeah. The important thing is not to try and do anything that could cause further injury. If you see them clenching their teeth, try and avoid putting anything into their mouth, because you can actually cause further damage by trying to put something into their mouth. Do not feed them, do not give them anything to drink while they're having the seizure, because they can actually choke on what you're giving them, because they have lost, there's impairment in their consciousness, so they have no control.
They're not aware of their surroundings.
Yes.
Okay. And so you've done that, but it's also important to call for medical assistance immediately. Is that correct?
Usually seizures last very brief they may last a few seconds to a few minutes. If the seizures are ongoing, they're lasting, it's been 5 minutes and the seizures are going on, then you need to call an ambulance, because prolonged seizures can be detrimental to the patient, as it can cause us hypoxia or lack of oxygen to the brain, and that can be harmful for the patient. So if you are seeing that the patient is having a prolonged seizure, or they're having multiple seizures and they are not recovering in between those seizures, that is considered a medical emergency and you should contact the ambulance.
Okay, so we've spoken a little bit about the emergency treatment. What about driving?
Okay. In South Africa, at this point in time, the law states that you cannot have a driver's license or go for a learner's test if you have uncontrollable epilepsy.
So when you mean uncontrolled, it means that you're having seizures on a regular basis?
You have ongoing seizures,
okay.
Yeah. You are on treatment, or you may not be on treatment because some patients are non-compliant, but you are having regular intermittent seizures. And those patients, according to our law at this point in time, should not be driving. If you've had a single seizure, the first seizure you've had in your life, you're not sure yet whether you have epilepsy. The first seizure, most doctors, the first unprovoked seizure, we generally don't prescribe medication. So in those patients, most doctors would suggest a waiting period of up to 6 months. If you have not had a seizure within that 6-month period, then it should be safe to say that you should be able to drive. Once you've confirmed that you're having recurrent seizures and that you are epileptic and you are on treatment, it depends obviously on the individual doctor, because there's no specific law in South Africa that says, oh, you must wait certain time. But we generally say that if you haven't had a seizure for 2 years, then it should be safe to return to driving.
Okay.
But it's on an individual, it depends on the type of seizure, what's the cause of the seizure. Certain patients that we know are more likely to have seizures, and therefore, much more of a hazard in driving. It all depends on the actual individual scenario.
Okay, okay. Can you maybe just tell the viewers some important points? We're about to wrap up the show. What's the take-home message on epilepsy, or the most important points that you can give to the viewers?
It's important to remember that up to about 50% of patients with epilepsy have no known cause. I find that most patients, wonder why they have epilepsy when the scans are normal, the bloods are normal, and they generally want more tests to find a cause. But 50% of patients can have no actual cause found, and that's the term idiopathic epilepsy. So that's the one thing that patients should remember. The second thing to remember is that once you're diagnosed with epilepsy, you should be very regular with your monitoring, with your and your follow-ups with your doctor, and you should be very strict with the medication. You should time it, take it exactly at the time that it's been advised, and never miss a dose. Because non-compliance is one of the biggest causes for breakthrough seizures in epileptics.
Okay, so with epilepsy, you can still lead a normal life if you're compliant. Is that correct?
Yes, you can lead a normal life. Things to just be wary of when you are epileptic, especially if you're still having ongoing seizures, is things like swimming. A person can drown if they are having a seizure underwater. So when you do swim, you should always swim with someone.
Okay.
Working at heights. If you fall from a higher level, then you are more likely to cause significant injury. So we usually don't advise patients who are epileptic to work at heights. Also, operating machinery and certain electrical equipment that can cause one error of judgment. If you have a seizure, it can cause damage, or it could be a hazard to you or to the people around you. So
it's more the hazardous environment, you
yeah.
would say. Okay. Dr. Motala, it's been a pleasure having you in the studio. Thank you for coming. Hopefully we'll have you on the show again. Thank you very much for watching. Stay tuned for another episode next week, same time, same place.